Episode 1 of Medical Legal Book. Clinical Cardiology, Decision-Making and Red Flags. Preface. This book was not written to add another title to cardiology shelves. It was written to replace the gaps those shelves quietly accept. Modern cardiology is rich in algorithms, trials, devices, and guidelines, yet poor in one crucial domain: the disciplined understanding of why patients deteriorate when everything appears to have been done correctly. Too many adverse outcomes are explained away as disease severity, patient frailty, or bad luck, when in truth, they follow recognizable patterns of anatomy ignored, physiology misread, judgment delayed, or responsibility diffused. This book exists to name those patterns plainly. Section 1. Introduction. Cardiac anatomy, physiology, and silent variants that kill. Cardiology failures often begin long before symptoms, procedures, or decisions, at the level of anatomy and physiology that is assumed to be known. This section revisits cardiac structure and microarchitecture not as static knowledge, but as dynamic determinants of risk. Coronary variants, myocardial bridges, papillary muscle anatomy, atrial appendage morphology, and microvascular behavior quietly shape outcomes, procedural safety, and embolic risk. These elements are rarely revisited once training ends, yet they explain many unexpected catastrophes. By restoring respect for silent anatomic variability and physiologic nuance, this section lays the foundation for understanding why standard algorithms fail when anatomy deviates. That understanding becomes essential as the book moves next into patients whose symptoms defy textbook patterns, despite apparently reassuring investigations. Now, Chapter 1. Coronary artery variants with catastrophic procedural implications. Clinical context. Coronary artery variants are structural modifiers of risk rather than incidental findings. Their danger lies in being interpreted through assumptions derived from standard coronary anatomy. Most adverse outcomes related to coronary variants occur during routine diagnostic angiography or low-complexity interventions. Catastrophic consequences arise from misrecognition, not from rarity. Variant anatomy alters catheter behavior, wire trajectory, perfusion dependence, and ischemic tolerance simultaneously. Anatomical and physiological trap zones. Anomalous coronary origins change ostial angulation and catheter alignment, increasing mechanical stress during engagement. Pressure damping occurs earlier in aberrant ostia due to altered flow vectors and reduced compliance. Myocardial territories supplied by variant vessels are frequently underestimated on angiography. Single vessel dependence is common in anomalous patterns and magnifies ischemic injury during transient flow compromise. Collateral assumptions fail in variant anatomy because collateral networks often mirror the abnormal origin rather than compensate for it. Pre-procedure red flags. Difficulty engaging a coronary ostium indicates abnormal origin until proven otherwise. Failure to visualize an expected artery in its usual sinus mandates anatomical clarification before proceeding. Symptom severity disproportionate to angiographic stenosis suggests altered perfusion territory or anomalous supply. Assuming dominance patterns without confirmation is unsafe in variant circulation. Proceeding without defining origin, course, and myocardial territory constitutes a decision error rather than a technical limitation. Intra-procedure catastrophic triggers. Forceful catheter manipulation at an anomalous ostium predisposes to intimal tear and ostial dissection. Deep intubation of ectopic vessels exaggerates pressure damping and precipitates acute ischemia. Guidewire advancement along presumed anatomical planes risks perforation when vessel trajectory deviates from standard epicardial paths. High-pressure contrast injection into aberrant origins produces hydraulic injury, spasm, and flow arrest. Interarterial and intramural courses are particularly vulnerable to transient compression during procedural manipulation. Post-procedure silent killers. Osteoedema, spasm, or microdissection in anomalous vessels may manifest hours after procedural completion. Electrocardiographic changes may be minimal or absent due to atypical perfusion patterns. Hemodynamic deterioration is frequently misattributed to sedation, volume shifts, or vasovagal reactions. Delayed recognition converts reversible ischemia into myocardial necrosis and ventricular dysfunction. You are tuned to Episode 1 of Clinical Cardiology, Decision-Making and Red Flags on Red Flag MD. Documentation that saves or sinks you. Failure to explicitly document anomalous anatomy implies non-recognition and is indefensible on retrospective review. Describing engagement difficulty as purely technical without anatomical clarification shifts liability to the operator. Absence of documented rationale for continuing, modifying, or aborting the procedure represents a critical documentation omission. Post-procedure notes must reflect heightened surveillance decisions based on variant anatomy. Never taught scenarios. Anomalous left coronary artery arising from the right sinus with interarterial course presenting as stable exertional angina. Single coronary artery supplying the entire myocardium misclassified as non-dominant circulation. Separate osteal origins of the left anterior descending and circumflex arteries mistaken for osteal stenosis. Injury to an anomalous right coronary artery during left system engagement due to shared sinus proximity. Guideline anchors. ESC Guidelines on Chronic Coronary Syndromes, 2019, Section 3.3, Paragraph 2. ESC Guidelines on Acute Coronary Syndromes, 2023, Section 6.1, Paragraph 4. ACC/AHA, Guideline for Coronary Angiography, 2021, Section 5.2, Paragraph 1. Clinical Cardiology, Decision-Making and Red Flags by Dr. Ravinder Singh Chani and Ripudaman Singh Chani. Section 1. Cardiac Anatomy, Physiology, and Silent Variants that Kill. Chapter 2. High takeoff coronaries and osteal injury during routine angiography. Page 26. Clinical context. High takeoff coronary arteries represent a positional abnormality in which the coronary ostium originates above the sinotubular junction. They are frequently unrecognized during angiography and misinterpreted as technical difficulty or catheter malalignment. The principal danger arises during routine diagnostic engagement, where forceful manipulation is used to compensate for unexpected osteal location. Most injuries related to high takeoff coronaries occur in otherwise low-risk diagnostic procedures, rather than complex interventions. Anatomical and physiological trap zones. High takeoff ostia alter the angle of coronary origin, increasing shear stress during catheter engagement. The absence of the protective sinus funnel effect predisposes the ostium to intimal trauma. Osteal elasticity is reduced due to altered wall composition and tension vectors. Pressure transmission during contrast injection is amplified because of reduced damping capacity. Pre-procedure red flags. Repeated failure to locate an ostium at the sinus level indicates possible high takeoff anatomy. Non-coaxial catheter alignment, despite multiple catheter shape changes, suggests abnormal origin. Pressure damping or ventricularization during partial engagement is a warning sign, not a benign artifact. Assuming osteal spasm without excluding high takeoff anatomy is unsafe. Continuing angiography without defining osteal height and orientation constitutes a decision error. Intraprocedure catastrophic triggers. Aggressive catheter manipulation above the sinotubular junction predisposes to osteal dissection. Deep intubation to compensate for unstable engagement increases the risk of circumferential intimal injury. High-pressure contrast injection against a partially engaged ostium causes hydraulic separation of intimal layers. Repeated catheter exchanges increase cumulative endothelial trauma and thrombogenicity. Post-procedure silent killers. Osteal edema following minor trauma may cause delayed flow limitation. Dissection flaps may not be angiographically apparent immediately after catheter withdrawal. Ischemic symptoms may be minimal or delayed due to transient reperfusion. Hemodynamic deterioration may be misattributed to sedation or contrast load. Documentation that saves or sinks you. Failure to document suspected or confirmed high takeoff anatomy implies lack of recognition. Describing engagement difficulty without anatomical explanation weakens procedural defensibility. Absence of documentation regarding cautious technique or modified catheter strategy increases liability. Post-procedure notes must explicitly mention osteal anatomy and its impact on monitoring decisions. Never taught scenarios. High takeoff right coronary artery, mistaken for osteal occlusion. Left coronary high takeoff, misdiagnosed as left main disease due to pressure damping. Osteal dissection presenting hours later as unexplained hypotension. Repeated diagnostic angiograms causing cumulative osteal injury in undiagnosed high takeoff anatomy. Guideline anchors. ESC Guidelines on Chronic Coronary Syndromes, 2019, Section 3.3, Paragraph 3. ACC/AHA Guideline for Coronary Angiography, 2021, Section 5.2, Paragraph 2. ESC Guidelines on Acute Coronary Syndromes, 2023, Section 6.1, Paragraph 5. I am Dr. Ravi Chani, Red Flag MD. This was Chapter 2 of Clinical Cardiology, Decision Making and Red Flags, available on Amazon. Now, Chapter 3, Myocardial Bridges, when benign anatomy becomes lethal. Clinical context. Myocardial bridging represents intramyocardial tunneling of an epicardial coronary artery, most commonly the left anterior descending artery. It is frequently labeled as a benign anatomical variant and dismissed during angiography. Clinical danger arises when dynamic systolic compression is underestimated or ignored. Ischemia related to myocardial bridging is effort-dependent, heart rate-dependent, and often absent at rest. Adverse outcomes result from failure to recognize the interaction between bridge physiology, tachycardia, and coronary flow reserve. Anatomical and physiological trap zones. Systolic compression extends into early diastole at higher heart rates, reducing effective perfusion time. Deep or long myocardial bridges exert greater compressive force and are associated with higher ischemic risk. Endothelial dysfunction proximal to the bridge promotes atherosclerosis despite a disease-free tunneled segment. Coronary flow reserve is disproportionately impaired during exertion or inotropic stimulation. Angiographic severity underestimates physiological impact because compression is dynamic rather than fixed. Pre-procedure red flags. Exertional angina with normal or near-normal resting angiography suggests dynamic obstruction. Ischemic changes on stress testing without corresponding fixed stenosis should prompt consideration of myocardial bridging. Failure to correlate symptoms with heart rate response represents a diagnostic omission. Labeling myocardial bridging as incidental without functional assessment constitutes a decision error. Proceeding to stenting without confirming hemodynamic significance increases procedural risk. Intra-procedure catastrophic triggers. Stent deployment within a bridged segment predisposes to stent fracture, restenosis, and thrombosis. Aggressive balloon inflation within the tunneled segment risks vessel rupture. Inotropic agents and tachycardia during procedures exaggerate systolic compression and precipitate ischemia. Misinterpretation of systolic narrowing as spasm leads to inappropriate pharmacologic escalation. Post-procedure silent killers. Persistent ischemia after angiographically successful intervention may reflect untreated bridge physiology. Arrhythmias may occur due to ischemia-induced electrical instability during exertion. Symptoms may worsen after stenting due to altered vessel compliance. Delayed recognition leads to repeated admissions labeled as non-cardiac chest pain. Documentation that saves or sinks you. Failure to document myocardial bridging as a potential cause of symptoms implies dismissal. Describing angiography as normal without noting dynamic compression weakens diagnostic credibility. Absence of documented rationale for conservative versus interventional management increases liability. Follow-up plans must explicitly address heart rate control and symptom monitoring. Never taught scenarios. Young patients with exertional syncope and normal coronaries harboring deep myocardial bridges. Athletes with sudden cardiac death risk attributed to presumed benign bridging. Post-stent recurrent chest pain due to untreated bridge physiology proximal to the stent. Myocardial bridging unmasked during sepsis or thyrotoxicosis due to tachycardia. Guideline anchors. European Society of Cardiology Guidelines on Chronic Coronary Syndromes, 2019, Section 3.4, Paragraph 2. American College of Cardiology Clinical Expert Consensus on Coronary Anomalies, 2020, Section 4.1, Paragraph 3. American Heart Association Scientific Statement on Coronary Artery Anomalies, 2020, Section 5.2, Paragraph 1. You've been listening to Episode 1 of Clinical Cardiology, Decision-Making and Red Flags, the first 3 chapters from Section 1. In total, there are 14 sections covering virtually complete clinical cardiology, every disease, condition, and procedure analyzed and explained medico-legally to help you identify and avoid red flags. Next episode continues with the next 3 chapters from Section 1. You were tuned to Red Flag MD. Subscribe, stay warned, stay safe. This content is for educational purposes only and does not constitute legal advice or establish a standard of care. Consult qualified legal counsel for specific cases.